levels. And there are now more and more long-term cohort studies beginning to appear that suggest that COVID does actually increase the risk of heart disease. And we've had Dr. Ray Duncan come on these calls quite often, and Ray's here today.
I'm a cardiology consultant, but I've been doing a lot of work in the long COVID arena since the beginning of the pandemic, both in research and clinical. So my cardiac clinic is probably not representative of your average cardiac clinic, because I do get quite a lot of long COVID referrals to me, but I'd say probably at least 50% of my clinic now is patients with long COVID with cardiovascular symptoms. Now, pre-pandemic, the average age range of my cardiovascular clinic was probably people aged 55 to about 80 years old. Now, the referrals I'm getting for individuals with long COVID with cardiovascular symptoms are aged 16 to 40. So most were completely fit and healthy young adults pre-infection. Most did not have underlying health conditions. They're disproportionately female, they're young, and they're previously fit. Many of them are now housebound. Several of them are bedridden completely. Some cannot walk, others in wheelchairs, some cannot even stand up. Some of my patients are now spending 20 to 23 hours a day in bed and can only manage to sit upright for 15 to 20 minutes at a time due to severe orthostatic intolerance, because the virus has damaged their autonomic nervous system and they cannot control their heart rates properly. Their collective stories are heartbreaking. And they're not recovering within a year, nowhere near it. And that's because of the reinfection rate, I think. I've seen so many patients who've had COVID, they've done okay, they've caught it a second time, they've developed long COVID, they've struggled to get better, they have improved, they've managed to get back to work, they've caught it a third time, and now they're bedbound, housebound, unable to walk. And some of them, I run a virtual clinic, so some of them can seek help from their beds because they're not well enough to sit up for long enough to come and sit in an outpatient clinic. They have become progressively more disabled with each subsequent infection. And this virus is running rampant. And I think this narrative that COVID is over is wrong. And I think allowing it to run rampant is providing a breeding ground for new variants to emerge. And I'm worried that some of these will exhibit more and more immune escape, and therefore the vaccines will be less effective. And I don't see how this is sustainable in the long term for these individuals. I am seeing the devastating impact of this virus on young lives that are being damaged on a massive scale. And it makes me sad, it makes me upset, it makes me angry, because some of this could be prevented, I think. And I think there is a need for public health teams to be extra vigilant on the emerging new variants. I think there is a need to try and reduce the reinfection rates from this virus, because we already know from published data that reinfection cumulatively increases your risk of long COVID and cardiovascular complications. And I think there needs to be a plan for the level of healthcare provision that we're going to need in the future going forward, looking at all these individuals. And I think because of that, it's important that population-based surveys are maintained, because if we don't look, we can't see.
They have very similar characteristics to XBB.1.5 and also XBB.1.16. We have two risk assessments that have been published that detail the increase in growth advantage that we've seen for these XBB sublineages, and that would also include XBB.1.9. We do see immune escape, which means people can be reinfected again, despite being previously infected or vaccinated.
An estimated 1 in 10 infections results in post-COVID-19 condition, suggesting that hundreds of millions of people will need longer-term care.
And with that, I just wanted to update you on some of the emerging research. I'm not going to go through everything that I've talked about on here previously, but just the very basics. So one of the things from a research perspective, from the cardiovascular research we're doing into this condition, is we know now that COVID is causing endothelial damage. And for those of you who haven't heard my previous presentations, that means the virus is involved both directly and indirectly through the host response in causing inflammation of the inner lining of the blood vessels. Now that's important to understand, because this endothelial dysfunction here, or endothelial damage, is involved in the precursor for the development of long COVID through platelet hyperactivation and microclotting, we believe. It's also involved in some of the larger blood clots that we're seeing. But in addition to that, endothelial dysfunction is the precursor for the development of atherosclerosis that causes cardiovascular disease. Now, I've shown this slide before. This was one of the original articles by Zayed Al-Ali's group from the Veteran Affairs that first demonstrated in an epidemiological study all of the excess cardiovascular morbidity that we were seeing in people that had been infected with COVID. I've showed loads and loads of papers now. There are papers from multiple continents looking at millions of patients, all showing the same thing, that there is a significant increased risk of cardiovascular complications after you've been infected with COVID. Not necessarily just people who develop long COVID, this is anybody that's been infected. So all I'm going to do today is just give you an update on another couple of papers that have subsequently been published since I did my last presentation on here. So this is one coming out of the UK, looking at 48 million patients, 1.4 million COVID diagnoses, and over 250,000 of those had an arterial thrombosis, which is a heart attack or a stroke, or a different form of arterial thrombosis, but mainly heart attack or stroke, within 12 months of index infection. That's a lot. This is another paper that also has come out of the UK and published recently, looking at the short and longer term risks of cardiovascular disease after being infected with COVID, and has demonstrated that people retain a significant elevated risk of cardiovascular death, as well as increased morbidity for up to 18 months after being infected with SARS-CoV-2. Obviously, we always get some people saying, how do you know it's not the vaccine? How do you know it's the virus? Well, this is a paper here from the Journal of the American College of Cardiology showing that if you have been vaccinated and catch SARS-CoV-2, and if you're unvaccinated, your risk of cardiovascular events is much higher if you are unvaccinated. And it appears from this study that vaccination confers some form of protection, although it doesn't give us complete protection, and you can still be at risk. We unfortunately know already in adults that the more times you get infected with COVID, the higher those risks become. You've got an increased risk of developing long COVID, so you may be infected once or twice and feel like you've got away with it, and then you get infected a third time and you develop long COVID, and then a fourth time, and it really knocks you back. And this is the kind of thing that I've been seeing in some of my patients in my clinic, unfortunately. But it also increases, reinfection increases your risk of cardiovascular complications, neurological complications, endocrine complications, GI complications, hospitalization, and death. What is COVID doing to our children? So we don't have much data on children, and partly this is because it was believed at the beginning that children weren't really affected, so the research had mainly concentrated on adults, but we're beginning to see some research coming out now. So at first, there was a narrative that believed that kids don't get COVID, and we know as time goes on that they do. Then it was that kids don't transmit, and we now know that they do. And this is just a slide that's come out from a public health department in the US suggesting that schools actually may be quite a major zone of transmission, because I'm assuming because schools haven't really got many protections in place. Children don't get sick with COVID. Well, we now know that they can do, and they can get both PIMS, TS, and long COVID. And certainly what we've seen up until recently and so far is that the majority of children seem to have a mild index infection, and it's assumed that they fully recover because they feel better. But I guess the question is, do they? Do we know that? And I've showed this slide previously before, but this is children that had a mild index infection, as well as a cohort of children with long COVID. The mild index infection group felt better, so they clinically fully recovered. But when we did specialist, not we, the German group did specialist scans of the lungs, there was evidence of subclinical organ damage in the lungs of both the children with long COVID, but also in the group that had had the mild clinical infection and felt okay afterwards. As I think David might have mentioned at the beginning, there has been some data suggesting an increased incidence now being seen epidemiologically in children who've been infected with SARS-CoV-2 of diabetes. Now, correlation doesn't prove causation, but that obviously needs to be looked at. But what I just wanted to really concentrate on, obviously being a cardiologist, is this paper that's just recently been published. This is a paper looking at the hearts of children after COVID infection. These are children, again, that had a mild index infection, were not hospitalized and felt fully recovered afterwards and did not develop long COVID. And in my kind of previous life before the pandemic and before I got involved in the long COVID work, my subspecialty is I'm a multimodal cardiovascular imaging specialist, and myocardial deformation imaging, which is the technique that was used in this study, is one of my areas of expertise. This is called strain imaging, and what it does is it uses an engineering technique to look at the deformation of the heart muscle, the myocardium, over time, and it gives us an idea of the contractile response of the heart muscle cells and how well the heart is able to contract and relax. And this technique's been around in research for about 20 years. It's more recently translated into clinical use, and we have seen in lots of disease processes so far, predominantly in adults, that it can give us very early insight into subclinical heart muscle damage that is not visible to the naked eye. And it can show over time that these may be individuals who could be at risk of going on to develop heart failure in the future in adults. Now, I don't want to over-egg this study because this is a very small study, but what it showed is that when they did strain imaging or myocardial deformation imaging on the hearts of these children, they took a group of children who had not had COVID, and they took a group of children who had had mild index COVID and clinically recovered. And they found that there appeared to be some subclinical contractile reduction in contractility in the hearts of the children that had been infected for several months afterwards. Now, that was it was statistically significant, but it was a small change. It was subclinical, so the children were not aware of it. They didn't have any symptoms of heart failure. I'm not suggesting that at all. It's an observation. It's a small study, it's cross-sectional. We don't know yet if these changes will improve over time. We don't know if they will normalize. We don't know if they will stay static. We don't know if they will get worse. So it's difficult to draw too many conclusions, and I don't want to be alarmist here, but that's what the study has showed. But my concern about this is if we are beginning to see a signal that COVID may be causing subclinical contractile abnormalities in the hearts of our kids, and we do nothing to reduce the reinfection rate, and we know that children are getting re-exposed to COVID repeatedly through school, and they get infected, and then they get reinfected, and then they get reinfected. And if our learning to live with COVID policy continues to be learning to live with COVID, meaning just accepting you're going to get infected maybe twice a year, my worry is what is that going to do to the organs of our children cumulatively over time? Because this isn't a cold virus, this is a SARS-2 virus. And my concern is how many infections can a child's body take repeatedly before they go on to become disabled adults? Now, I don't know the answer to that. I don't think anybody knows the answer to that. I don't know if that will happen or not, but I don't think we should be sitting back and playing roulette and waiting to find out. I think really we need to have a serious think about how we reduce the reinfection rates, how we try and protect our kids, how we try and protect our citizens, how we invest in clean air, how we reduce the risk of catching this. Because at the moment we do not have a cure. We have a lot of potential treatments that may be helpful. And again, I've just been on a research call this morning. It was very exciting and interesting looking at other things that we could be trialing. But again, we need investment in studies. We need studies to be fast-tracked. We need more treatment trials. And then we can be able to look at some of these medications that we could be rolling out. But we're quite away from that yet. And so at the minute, I really strongly feel that the precautionary principle has to be applied.